Hello, my name is Patricia Hall Eidson. I'm pleased to be back with you today to present our WHO policy updates on the use of targeted next-generation sequencing end-to-end solutions for the detection of drug-resistant TB. First, I'll provide background on next-generation sequencing, or NGS. Then I'll present our WHO recent and forthcoming policy on the use of targeted NGS for clinical management. And lastly, provide some next steps and resources. While we recognize that many in the audience may be familiar with next-generation sequencing or even have expertise with its hands-on use, others may be less familiar. And so what I'd like to do first is review a series of definitions in the process before we talk about the policy guidance. Next-generation sequencing, or again, NGS, is a high-throughput sequencing method that is used to determine the nucleotide sequence of a genome in a single biochemical reaction. It is in general done using 4 steps, the first of which is where the bacteria are lysed and DNA is extracted and purified. That DNA is then prepared in a library preparation second step. And once prepared, the DNA can then be sequenced in the third step. This is where the nucleotide order is determined. Once the sequences have been produced, then they can go into the fourth step, which is software analysis, where the sequences are assembled, they're mapped, and the nucleotides are compared against those of a reference sequence to identify where there may be changes. This is where mutations, for example, are identified. Since next-generation sequencing is a method, the method can be used in 2 ways: to produce whole genome sequences or targeted next-generation sequences. In whole genome sequencing, shown here, the MTB genome, shown as the blue circle on the left, is sequenced in its entirety. So the whole genome produces the brown outer circle. This investigates the entire genome as the most comprehensive approach. However, it does have less depth, so you get fewer reads at each point of the genome. It requires TB culture, which leads to a longer turnaround time, and it requires more data capacity for storage as well as analytics. However, it's the most useful for surveillance because you have the full nucleotide sequence of the genome and therefore can compare one organism's full sequence to that of another organism. In targeted next-generation sequencing, NGS is used to target specific areas of the genome, in this case, those that are known to harbor mutations associated with drug-resistant TB. These are the segments that are shown on the left. It's adaptable to new genes through the addition of new primers. It's in-depth, so you'll see more segments there at each point of the genome. And it has a faster turnaround time as it can targeted next-generation sequences can be produced from primary clinical specimens or sputa, making it useful for clinical care. It also has less data usage and storage and analytics capacity requirements compared to whole genome sequencing. So let's quickly look at the history of WHO recommendations for next-generation sequencing. These first started in 2018 with the release of a technical guide on the use of next-generation sequencing technologies for the detection of mutations associated with drug resistance in Mycobacterium tuberculosis complex, as alongside a technical manual for drug susceptibility testing that updated critical concentrations for use of phenotypic DST to which TNGS results can be compared. In 2021, WHO released the first guidance for surveillance of drug-resistant TB that recommended the use of next-generation sequencing for this purpose, as well as a target product profile for next-generation's drug susceptibility tests at peripheral center, and the first WHO catalog of mutations in Mycobacterium tuberculosis complex and their association with drug resistance, serving as the first globally standardized reference resource for interpretation of sequence results, as well as to guide development of manufacturers in developing new sequencing assays. In 2022, WHO released new consolidated guidelines on TB drug-resistant treatment, which led to needed changes in drug susceptibility testing profiles. In 2023, the second edition of the Catalog of Mutations of MTB complex and their association with drug resistance was released that incorporated the latest information regarding mutations associated with resistance for updated interpretation guidance. And importantly, WHO released for the first time a rapid communication on the use of TNGS to detect drug-resistant TB for clinical care. In addition, WHO released a next-generation sequencing surveillance of drug-resistant TB implementation manual. Last year, this information, particularly compiling the rapid communication recommendation on the use of TNGS for drug-resistant TB, was incorporated into the consolidated guidelines on TB diagnosis, with further information available in the operational handbook, and the target product profiles for TB diagnosis and drug resistance testing were updated. And then most recently, just this past month, the WHO Consolidated Guidelines on Tuberculosis 2025 Module 3 diagnosis were released. And so this incorporates the latest evidence, and the operational handbook is forthcoming. So within the latest guidelines, we have recommendations on the use of targeted NGS to diagnose drug-resistant TB. These are included in a specific class-based section where a new diagnostic class of targeted next-generation sequencing solutions was established. These are defined as using massive parallel sequencing to detect resistance to TB drugs, starting from a processed clinical sample and ending with an end-user report that relates Mycobacterium tuberculosis mutations to the presence or absence of drug resistance based on the interpretation of a standard catalog of mutations. These solutions, again, start with a processed clinical sample and include procedures and instrumentation to go through all of the 4 steps we reviewed on targeted next-generation sequencing in order to produce that end result. And the products that were included in the classes for first-in-class technologies are listed here. These included the Dplex MycTB assay, the Ampor TB assay, and the TB-Seq reagent kit. The drugs for which they were initially recommended for detection of resistance are listed with each of the products. TNGS, through the guideline development group process, was found to be accurate for drug-resistant TB detection. Among people with bacteriologically confirmed TB, it was accurate for all drugs assessed, with a pooled sensitivity of greater than or equal to 95% for rifampicin, isoniazid, moxifloxacin, and ethambutol, 94% for levofloxacin, and 88% for pyrazinamide, with specificity high for all drugs. Shown on the right, among people with bacteriologically confirmed rifampicin-resistant pulmonary TB, the technology was found to be accurate for the detection of resistance to isoniazid, levofloxacin, moxifloxacin, pyrazinamide, and ethambutol with pooled sensitivity of greater than or equal to 95%. These are highlighted as yellow in the table, and acceptable for bedaquiline, linezolid, clofazimine, amikacin, and pyrazinamide, orange in the table due to the lower sensitivities. Specificity was greater than or equal to 95% for all drugs except for streptomycin. And importantly, this was also found through systematic review of evidence to be cost-effective depending on the setting and the context, acceptable and implementable despite acknowledging the inherent complexity associated with the technology. So these are the 2 recommendations with the remarks for the use of this technology for drug-resistant TB. On the left, we have in people with bacteriologically confirmed pulmonary TB disease, TNGS technologies may be used on respiratory samples to diagnose resistance to the first-line TB drugs. However, the remark highlights that priority should be assigned to those at higher risk of resistance to first-line treatment, such as those that continue to be smear or culture positive after 2 or more months, have previously had TB treatment, are in contact with a person known to have resistance to TB drugs, or reside in settings or belong to subgroups where there's a high probability of resistance. On the right, we see the recommendation among individuals that have bacteriologically confirmed rifampicin-resistant pulmonary TB disease, highlighted in orange. The TNGS technologies may be used on respiratory samples to diagnose resistance to isoniazid and second-line TB drugs, where again, priority should be given to those at a higher risk of resistance to medications used in the treatment of rifampicin-resistant TB. This will ensure that the patients that are at higher risk for resistance have access to the technology and receive drug susceptibility test results more rapidly than phenotypic-based testing. There were multiple implementation considerations for the use of this technology, but I would like to highlight just a few here. In particular, that targeted NGS does not replace existing rapid tests that are more accessible and easier to perform for detecting resistance to RIF, INH, and fluoroquinolones. However, if it can be performed rapidly, noting particularly the widespread capacity in the European region, it can be considered as an alternative initial option for prioritized populations. Priority should be given to samples with a high bacillary load as determined by initial bacteriological tests, because where the bacillary load is low, indeterminate results are likely to be higher, and culture-based DST is still likely to be required to get a final drug susceptibility testing result. In particular, there were additional considerations for the use of TNGS for detection of resistance to bedaquiline, clofazimine, and linezolid. Since TNGS sensitivity for these drugs is suboptimal, phenotypic DST should also be done. Consideration of pretest probability is important, as shown in the table on the bottom, where you see the outcome of true and false positives and negatives on an effect of 1,000 patients tested across a range of pretest probabilities. If risk of resistance is low, the susceptible results may be used to guide therapy, where you can see at a lower pretest probability, the number of false negatives is much greater than, or lower than the number of true negatives. However, that number increases as the pretest probability increases. If risk resistance is high, both susceptible and resistance results should be used with DST to guide therapy. And this is particularly important as you see at the pretest probability higher rates, the number of true positives now outnumbers the number of false positives, allowing more confidence in a result. In addition to these first-in-class and 2023 findings, advances in TNGS solutions have occurred recently. With one solution shown here on the top, the ONT Ampor TB reagent kit, and one other solution, the one shown on the bottom, the ABL Diagnostics SA Deep Check assay, either having updated software solutions, as was the case of Ampor TB, or an updated or complete final data set that were available for WHO to assess. Based on these recent advances, WHO put out a public and a targeted call for evidence, and the evidence review was completed in January this year by the WHO Technical Advisory Group. The solutions were assessed again for the detection of first-line drug resistance among people with bacteriologically confirmed TB and second-line drug resistance among people with rifampicin-resistant TB. What I'm showing here is the tables that compare the Ampor TB performance in the dark blue columns with the TNGS within class pooled performance across the initial drugs that were first, or the initial products that were first in class for both bacteriologically confirmed TB in the table on the top and rifampicin resistant TB in the table on the bottom. The Ampor TB drug sensitivity and specificity values that are either equivalent or slightly improved compared to TNGS within class are highlighted green, whereas those that are slightly below the TNGS within class or are not comparable are in orange. And what you can see is based on the software update for this solution, it overall saw increases in performance for rifampicin, the fluoroquinolones, pyrazinamide, bedaquiline, linezolid, and amikacin, while experiencing a slight decrease in performance for ethambutol compared with the overall class. Based on these and other findings, the performance of the Ampor TB solution was determined by WHO this year to be comparable to that of other WHO-recommended TNGS solutions for the detection of resistance to the first-line drugs among the bacteriologically confirmed individuals, and isoniazid fluoroquinolones, bedaquiline, linezolid, clofazimine, pyrazinamide, amikacin, and streptomycin among people with rifampicin-resistant TB. Unfortunately, there was insufficient evidence to compare the deep check assay against that of WHO-recommended TNGS solutions, so it could not be adequately compared for a recommendation at this time. In summary, the WHO recommendations for the use of TNGS are valid for the updated Ampor TB ONT solution, which now meets class-based performance criteria for the detection of resistance to 3 additional drugs. This includes pyrazinamide, bedaquiline, and clofazimine, for which the solution was not originally recommended for detection of resistance. Lastly, I would just like to highlight it that in the operational handbook, the new drug susceptibility testing algorithms include a route for the use of TNGase-based DST, and there are also information sheets for each of the recommended solutions included. The 3 TNGS solutions recommended by WHO for detection of first and second-line drug-resistant TB were covered here today. Their forthcoming 2025 operational handbook on TB diagnosis will include new solution and policy statements and underlying reports and should be released over coming weeks. Advances in our understanding of the molecular mechanisms associated with resistance are expected to improve solution performance over time, similar to what we saw with the AMPOR TB, as we understand more of the mutations that underlie resistance and can reflect those in the WHO mutations catalog. Then manufacturers can update their solutions to improve performance, and these updates will undergo WHO review and assessment. While more evidence is needed on new drugs and impact of TNGS on patient-important outcomes, and WHO also encourages submissions to the TB sequencing portal of whole genome sequencing and phenotypic results. Alexei, who's present at the workshop, can share more information. In addition, please also be aware that WHO is working to release an updated version of the mutations catalog this year, that in collaboration and leadership of WHO Euro, WHO is planning to release a WHO Academy e-course on targeted next-generation sequencing, for which Sudhe is an excellent point of contact at the workshop this week. And a WHO pre-qualification process for the development of TNGS solutions is underway so that future products, as they are developed, can go straight for pre-qualification after they are initially reviewed by our WHO Global TB program for within-class determination. With that, I would like to thank Alexei Korobitsyn for contribution to the slides and for leadership of our guideline development process. All of the members of the technical advisory group and guideline development group meetings, and as well as the national TB programs, persons affected by TB, and our funders and contributors to the work. Thank you very much.